It's live.
What is that? Nudge, ready to go? Can you hear me all right? That's a lot. All right, let's make a start. Hi everyone, my name's Julien. I'm currently a Year 4 student at Peninsular Health. This is part one of two lecture series, two lectures on the gastrointestinal and hepatobiliary system. There's a lot of information on the slides. So rather than trying to copy like a lot of what's on the PDF onto a Word document, just try and pay attention to what I'm saying, and I'll try and emphasize the key points. So we've got a lot to get through, so let's get into it. So that's what we'll be going through today. We've tried to incorporate some OSCEs and some EMQs and a few different things, along with some of the matrix conditions. So we'll be going through upper GI today, and then next week we'll be going through lower GI as well. So just a bit of anatomy to start with before we move on to the pathology. So the esophagus, obviously a long muscular tube involved in peristalsis. There are 4 major constrictions. It's C6 and T10. So C6 with the pharynx, T10 when it passes through the diaphragmatic hiatus, and then T4 and T5 as well. There's the arterial supply, but I guess the relevant part for today is looking at the sphincters. So there are 2 sphincters. There's a functional sphincter and an anatomical sphincter. So the functional sphincter is the lower esophageal sphincter, which is at T10. And the anatomical one is at the end of the stomach when it joins onto the duodenum at the pyloric sphincter. Now, the reason these two are significant is the functional sphincter, or the physiological sphincter, lacks a localized thickening of muscle. So it achieves contraction using external muscles or muscles around it, i.e. the diaphragm. The anatomical sphincter down the bottom of the stomach has a localized thickening of muscle, and that facilitates its action as a sphincter. So why this is significant is because the lower esophageal sphincter, the functional one, stops gastric juice from retrograde flow or going back into the esophagus. And obviously there's a problem with that in GORD. So GORD, which is gastroesophageal reflux disease, is pretty self-explanatory as it suggests. And this valve, or this sphincter that we were talking about, prevents complications. What are the most significant ones being metaplasia, also known as Barrett's esophagus, where the stratified squamous epithelium is converted into simple columnar epithelium, and a few other things like reflux esophagitis and eventually esophageal carcinoma. So in a lot of people, you get physiological reflux, which is normal. It's short-lived. It might be after a heavier meal than usual. That's nothing, out of the ordinary. But if it happens over a long period of time, many episodes, often at night as well, because when people are lying flat, that can tend to worsen their GORD. And then when you get symptoms and complications and then changes on biopsy, that's when you know you've got a problem. Just briefly with esophageal cancer, if detected, it requires close surveillance via gastroscopy, as it significantly increases your chance. Sorry, Barrett's esophagus, if you've detected Barrett's esophagus, it needs close surveillance by gastroscopy, as it significantly increases your chance of developing adenocarcinoma. And if you do have adenocarcinoma, then you can look at resecting that and also giving high-dose gastric suppression as well, gastric acid suppression. So in terms of the main symptoms, the main ones are heartburn, so that burning sensation in the retrosternal area, most commonly postprandial after a meal, acidic regurgitation. So often when lying flat, some of you might have experienced it when you get a bit of acid mixed with a bit of food coming back up. Water brash, is another one, which is, I guess, hypersalivation and a bit of an acidic taste in your saliva, belching and burping, a dry cough. So if you get a OSCE station which asks for cough, it's also important to think about GORD. It's often a dry cough and often nocturnal, as we talked about before, and dysphagia, which is, anyone? Yeah, good, difficulty swallowing. And that's often something you develop a bit later, potentially indicative of a stricture, and it's important to investigate the cancer if you have a patient with dysphagia. In terms of management, we always use our three-pronged attack, so always start with lifestyle management, so looking at weight loss, elevating the head of the bed, trying to identify, certain people have trigger foods and trying to identify what those are and removing them from the diet. Pharmaceutical management, proton pump inhibitor. These are the most potent inhibitors pharmaceutically of gastric acid secretion. They irreversibly bind to the hydrogen potassium ATPase pump. A typical proton pump inhibitor is esomeprazole, and you can give that, I think, 20 milligrams orally daily, and you generally give it about 30 minutes to an hour before someone's meal. So that often does the trick, but if not, you look towards surgical management in people with chronic GORD, and that's laparoscopic fundoplication. Anyone know what a fundoplication is? Some of you might have seen one. Very briefly.
You take the fundus of the stomach and you wrap it around the floor of the esophagus.
Yeah, perfect. Yeah, so Charlie? Yeah, exactly as Charlie said. You wrap the fundus of the stomach around the esophagus, and it essentially reinforces that lower esophageal sphincter. Okay, so that's good. So moving on with esophageal pathology, achalasia. So it's a motility disorder, and it's due to incomplete relaxation of that lower esophageal sphincter. There's thought to be neurological involvement. So there's progressive degeneration of some of the cells in the myenteric plexus, myenteric being that motor plexus in the distal esophagus. Presentation can be very similar to GORD and other esophageal pathologies. Diagnosis, this is really important. So there's barium swallow studies and esophageal manometry. So with barium swallow, essentially what the patient does is they swallow a fluorescent barium solution, and then you take lots of x-rays, and you sort of observe the flow of that fluorescent liquid through the esophagus. And manometry is when you put a tube in the patient's nose, and you ask them to swallow a lot of times, and you can sort of measure the peristalsis, or measure the muscle contractions occurring in different parts of the esophagus. There's treatment options as well. So pneumatic dilatation is when you just forcefully put a balloon through the lower esophageal sphincter, and surgical myotomy is when you cut some of the lower esophageal muscle fibers. So this is an important bit for your exams and your buzzwords. The appearance on barium swallow is a bird's beak or a rat's tail. Okay, so that's very important. Important things, really important things are in red. Relatively important things are in blue. And I'll show you a picture of that in the next two slides. This is also a chest x-ray of achalasia, and those arrows are pointing to the outline of a very largely dilated esophagus. So that's achalasia. So predominantly, it's that neurological component and incomplete relaxation of the lower esophageal sphincter. Another one is diffuse esophageal spasm. So again, it's a motility disorder, and this was taken from Up to Date, so I'll just read it because it pretty much sums it all up. Although the underlying pathology is unknown, DES has been associated with impairment on inhibitory innervation, leading to both premature and rapidly propagated or simultaneous contractions in the distal esophagus. And it can sort of lead to deposition of fibrous tissue over time. So the appearance of barium swallow, is a corkscrew esophagus, and I've got another picture of this. Very briefly, eosinophilic esophagitis. The main finding is eosinophils when you look at their full blood count. A few things compared to GORD, it's more common in males, and it's often associated with food impaction. That's one of the sort of symptoms that you probably wouldn't usually see in GORD or DES, but it's quite common in eosinophilic esophagitis. All right, so we've got two pictures of barium swallows on the slides. Does anyone want to tell me what the left one is? So first tell me what the sign is, and then what the disease is. So what's the sign? Anyone? I've mentioned them both. Yep, the rat's tail or the bird's beak. And what's the disease then, Mac? Yep, achalasia, good. And the one on the right, it's the other one we talked about. Anyone? Come on, guys, we did it 20 seconds ago. Yep, thanks. Corkscrew esophagus, which is involved in diffuse esophageal spasm. Okay, so make sure you remember that for your gastro-EM cues. That's the esophagus. All right, so we'll just have a little bit of an activity now. So what I want you to do is grab a pen or a paper, or you can do it on your Mac, which pretty much everyone has a Mac. I'll take about a minute and 30 seconds, and I want you to have a go at this activity on the slides. And try not to look to the next slide, because that has all the answers. So this might very well be your OSCE stem. The presenting complaint is difficulty swallowing. So write as many differentials as you can think of. You can work together. Good question. That's all that will be on your stem. So that's good. That's a good question to ask. Yeah. You won't get something that specific going into your OSCE. It'll be very general. So you can work together if you want, or you can do it yourself. All right, that's enough time. So this is pretty much how I would, in my 2 minutes reading time, if I was brilliant enough to think up all these, I would write them down. But that's kind of what you should be aiming towards doing. So with your WWQQ-AAB, it's very stock standard. Just with when, sometimes it might be relevant. Often with presenting complaints in third year, it's often good to ask how many episodes they've had and if they've ever had it before. As gentleman in the front mentioned, good question to assess with quality. Is it solid? Is it liquid? Is it saliva only? And there's a commonly associated symptom of pain on swallowing with dysphagia. So this is the way I categorize it, by system. So neurologically, if something which is involving more nerves than just the ones to do with the esophagus, something specific to the esophagus, so GORD, one of the esophageal motility disorders, stricturing, which you can see in Crohn's, which we'll talk a bit about next week, a cancer. It doesn't just have to be an esophageal cancer. A lot of gastro cancers can be lymphoma as well, or multiple lymphomas. And then you've got to think about extramural compression from a lung cancer or a thyroid cancer as well. And then there's a myriad of other things as well, including scleroderma. What's a syndrome you see in scleroderma? Has 5 letters and they all stand for something. CREST. Yeah, so calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Okay, so that's CREST, which is under kind of your rheumatoid conditions. But the E stands for, the E or the O stands for esophageal dysmotility. In terms of investigations, we've already really talked about them, but full blood examination, and then you can kind of gear it towards what you think the etiology is. So is it a neurological cause? Then you might consider manometry. Is it something mechanical? So you might want to do a barium swallow. You might want to do an endoscopy, and you might consider doing a PET scan as well if you think it's a cancer. All right, so that's dysphagia. We won't do the same for vomiting, but what are some causes of vomiting? So just yell them out, just a few. Yep, gastroenteritis, that's one everyone thinks of. What are some other GIT ones, just quickly? It's pretty much anything. Small bowel obstruction, good. Yep, so appendicitis, pancreatitis, there's lots of GIT ones. What are some other ones not in the GIT system category? Yep, pregnancy, very good one. I have no idea what that is, but yeah, let's go with that. So you can think of endocrine. Often when you're looking at GIT systems reviews, endocrine and gynae are often systems that have a lot of presenting complaints, which are similar. So some other ones I thought of were anything with severe sepsis or severe infection. So if they've got really bad pyelonephritis, a really bad meningitis that can lead to nausea and vomiting. Endocrine categories, so hypercalcemia, groans, moans, stones, etc. DKA potentially. And then there's lots of other ones, which we'll get to a little bit later. So that's the definition of vomiting, quite self-explanatory. When you're going through ruling in and ruling out, asking about the nature of the vomit. So is it feculent vomit, which might suggest what? Yeah, a large bowel obstruction. If there's frank red blood, it could be like a Mallory-Weiss tear or an esophageal tear. Or if it's coffee ground vomitus, it might be from the stomach or the duodenum because it's had time to digest before it comes back out. So asking about the nature of the vomit is important. If there's bile or not in the vomit. So generally bile-stained vomit is below around the duodenum, generally. Whereas you can sometimes see projectile vomit. Projectile vomiting is quite classically seen in pyloric obstruction because of the pressure, it just goes straight back out. So asking if, was it green or was there bile or was it not precipitated by nausea? So a lot of vomiting cases, you'll get nausea before. In projectile vomiting, they don't have time to get nausea, it just goes straight out. A lovely image there. Consider, there's a few other things. So I think someone mentioned pregnancy. There are a few other ones you can think of as well. So anorexia and bulimia as well. Raised intracranial pressure, we kind of mentioned with meningitis. And just be aware that you need to treat severe fluid and electrolyte imbalances as well. Okay, so this is taken out of Murtaugh's GP book. So he has a different way of classifying things. He goes through a probability diagnosis, then serious disorders you shouldn't miss, pitfalls which are commonly missed in general practice, 7 masquerades. So he has this list of 7 conditions which he asks for every single presenting complaint. And then there's a patient trying to tell me something, which is generally your yellow flags type system or your mental health type questions. It's quite advanced to think about it in the state of anosky, but it's just another way of categorizing information. All right, so moving on to the stomach. Okay, so I'm not going to go through all of that, mainly because I can't remember it. But essentially with the anatomy of the stomach, so as we talked about before, we've got the lower esophageal sphincter, the cardia, the fundus, sorry, the cardia and the fundus. We've got the body of the stomach, the pyloric antrum, the pyloric canal, and then the pyloric sphincter. What's the role of the stomach? The conversion of a food bolus to chyme, which then goes down through the duodenum and has all the pancreatic juices and bile added to it. I want to talk a little bit about the vasculature. So this is significant. So the celiac trunk divides into 3 main branches. You have the left gastric artery, which is this one here. You have the left gastric artery, sorry, the common hepatic artery, which is there. And then the other one you have is the splenic artery. And that's the one that continues behind the stomach. So the splenic artery is really important. Can anyone tell me why or what I might be alluding to? Why is the splenic artery important in a clinical context?
Erosion of the posterior aspect of the stomach and then damaged artery.
Perfect. Excellent. So it's obviously very important in gastric ulcers. Okay. One of the complications of gastric ulcers is perforation of the artery. For some reason, Monash likes when you remember that. So just remember gastric ulcers, commonly erosion of the splenic artery. Duodenal ulcers, it's the gastroduodenal artery, which I think is that one there as well. So that's why the vasculature is significant in peptic ulcer disease. One of the most common complications of long-standing peptic ulcers is hemorrhage. So what is an ulcer? In a gastric or a GIT context, it's a break in the mucosal lining, and it results from an imbalance of factors. So you have factors promoting mucosal damage, and then you have factors promoting gastroduodenal defense. So what are some factors that might damage the lining of the stomach? Anyone? Pardon? NSAIDs? Working all right?
Yeah, it's on the wrong thing.
Okay. NSAIDs, yep. Anything else? Anyone? Okay, so NSAIDs is one of them. Helicobacter pylori infection, very, very common cause of ulcers. And then it's just, I guess, the acidic environment of the stomach in general. If you think about what's in the stomach, it's, gastrin, hydrochloric acid, pepsin. The stomach is naturally a very acidic environment. In terms of defense, you have mucus bicarb, the junctions, or the junctions between the cells in the stomach are quite tight. And the lining of the stomach is pretty good in that if there's damage, it can repair itself more readily than normal tissue. So yeah, it results in an imbalance which favours those factors that promote mucosal damage rather than gastroduodenal defence. In terms of comparing the two, duodenal ulcers are more common. Patient age group, I mean, they're generally both middle-aged men, but if you want to be really specific about it, again, red is important. So gastric ulcers, the pain is generally worse with meals. It can be, about 30 minutes or an hour after a meal as well. So it's when the stomach is full of contents, and a duodenal ulcer is worse quite a significant while after a meal. So generally about 2 or 3 hours after eating, when the stomach is empty. Okay, so that's quite important as to what's irritating what at certain points in time. In terms of gastric ulcers and duodenal ulcers, H. pylori is the top of the list, but with chronic NSAID use as well, due to the effects it has on prostaglandins, can also cause gastric ulcers. The risk factors are there. Pretty much a risk factor for any condition is past medical history and family history, so they're easy ones to rattle off in an OSCE. And triggers that we talked about before, so alcohol, tobacco, hot and spicy food. Presentation, burning, epigastric pain. Often the word burning is quite specific to gastrointestinal things, but also peptic ulcer disease. Hematemesis and melena, which we'll talk a little bit about later, and a few others. In terms of investigation, so an easy one to do on the bedside is a urea breath test, which is for H. pylori infection. And the reason they do that is it's based on the Helicobacter pylori's ability to convert urea and ammonia to carbon dioxide. So the patient swallows some radioactively labeled urea. You measure the levels in about 10 or 30 minutes, and then you can sort of see how much radioactive carbon dioxide is coming out, which will sort of indicate that the H. pylori is inside and it's metabolizing that urea and producing carbon dioxide. Does that make sense? Cool. And it's really easy to do. So it's a very good way of suggesting that H. pylori might be there. Always good to do an FBE, specifically because peptic ulcer disease is a very common cause of upper GI bleeding. So you want to check if there's what type of anemia? Yeah, microcytic anemia. Yeah, iron deficiency, microcytic anemia. Good. Imaging, gastroscopy, and others if necessary. In terms of treatment, so lifestyle, always start with lifestyle, and it's just cessation of risk factors. Pharmaceutical, triple therapy. These are taken off the RACGP guidelines. Sorry. So a proton pump inhibitor and amoxicillin and clarithromycin. They do also say that often with an amoxicillin allergy, you can replace that with metronidazole as well. Some people refer to quadruple therapy, where you can add bismuth chelate, which is just one of those cytoprotective agents. So one of those, it's essentially an agent that sort of promotes gastroduodenal defense. And then if perforated, that's when you're in a bit more strife. An urgent laparotomy, and you need to resus straight away. Nil by mouth with an NG tube, and then look at urinary catheterization for fluid output, and a group and hold if they need a blood transfusion, if it's really bad bleeding. Potential complications of peptic ulcer disease. So a lot of these terms kind of sound the same, but they're a little bit, there are nuances in their differences. So hemorrhage, and we've got a nice picture of iron deficiency anemia there with hypochromic microcytic, a hypochromic microcytic picture. So with hemorrhage, it's associated with hematemesis, so vomiting up blood, melena. A friend told me that they had a friend called Melena, which is interesting, but there you go. Sorry if you're listening. So iron deficiency anemia, and then potentially, if it's really bad, hemodynamic instability. And as the girl in the red and white jumper, sorry, what was your name? Sophia? Yeah, Sophie, said, yeah, it's exactly right. The ulcer can erode through a vessel posteriorly. So in the case of gastric ulcers, it's the splenic artery. Perforation, so this generally refers to when the ulcer perforates through the anterior wall of the stomach, and that can lead to peritonitis or inflammation and infection of the peritoneum. 1, 2, 1, 2, 3. Okay, so the third point should be penetration, and that's when the ulcer actually goes into the pancreas. So the pancreas posteriorly, causing a pancreatitis. Obstruction. So this is thought to be due to fibrosis. So whenever you get chronic inflammation in GIT, it often always leads to fibrosis. It's more important in tubes or parts of the bowel. So fibrosis, you can get stricturing, but it's also important here where the pylorus sort of gets smaller in diameter. So it can actually cause a pyloric obstruction, and then malignancy. So this generally is if H. pylori causing peptic ulcer disease is left untreated, the chronic inflammation and all those inflammatory mediators secreted by H. pylori can not necessarily cause multiple lymphoma, but predispose you or increase your risk of getting a gastric multiple lymphoma as well. So they're the 5 potential complications of peptic ulcer disease. The biggest one you need to be aware of is hemorrhage and causing an iron deficiency anemia. Just a quick note on autoimmune gastritis. So again, a brief bit of anatomy/histology revision. So in autoimmune gastritis, you have an immune-mediated attack on the parietal cells. So the parietal cells do 2 things, which are both mentioned on the slide, so I won't ask them. But one of them is they secrete hydrochloric acid. That's important because the chief cells secrete pepsinogen, and the hydrochloric acid is needed for the pepsinogen to be converted into pepsin. But getting back to the parietal cells secrete hydrochloric acid, but more important in this case, they also secrete intrinsic factor. Now, intrinsic factor, you need intrinsic factor to absorb vitamin B12 into the small intestine, or the ileum specifically. And if you don't, it can lead to what's called a pernicious anemia. So on a blood film, so yeah, again, pernicious anemia, very commonly associated with autoimmune gastritis. So keep that in mind for your EMQs. On a blood film, so it would appear as a megaloblastic macrocytic anemia. And with vitamin B12 deficiency, you can have lots of problems, including altered bowel motility. And you can also get neurological symptoms. So when you go over peripheral neuropathy and you learn the 10, 15 causes of them, vitamin B12 deficiency is a cause of peripheral neuropathy as well. If I was at Monash and I was writing an exam question about autoimmune gastritis, I'd probably put in the patient's past medical history that the patient has other autoimmune conditions. It's a known fact that if you have one autoimmune condition, you're more likely to have others. So there seems to be some kind of correlation between a few other autoimmune conditions which are listed on the slide as well. So that's the stomach. We all going okay? Okay, no one's moving. All right. Common presenting complaints. So weight gain and weight loss. This is the last one we'll do. And then I'll just go through the rest of them. But same as before. I'll give you in a minute 30. So this is your OSCE STEM. Mary Saunders is a 23-year-old female who presents to you accompanied by a mother after 3 months of intermittent weight loss. Take a focus history. So same as before, you can work with each other. I'll give you about a minute and a half. All right, so without looking at the next slide, can we just yell out a few differentials?
Stress.
Yep. Good. It doesn't say how much weight loss, so stress is a highly likely probability. Yep, anorexia nervosa or bulimia.
Celiac.
Yep, celiac or any other malabsorption disorders like Crohn's and things like that as well. Yep. Any others? Pardon? Yep, malignancy. Less likely in a 23-year-old, but it still happens. Yep, hyperthyroidism, so an increased metabolic rate and weight loss. Good, all very good suggestions. So again, go back to Murtaugh's one. I've highlighted probably some of the ones that are more important. So, bam, bam, stress and anorexia nervosa. Probably more specific in the way I wrote this stem. The fact that she's an adolescent in the broader schemes of disease makes it more likely that it could be stress or a possible eating disorder in that context. Also the fact that she's accompanied by a mother, so maybe that suggests that she doesn't really want to be there or be brought in herself. But yeah, so the stress, anorexia nervosa, malignancy, pretty much any malignancy can give you weight loss. Chronic infection as well, just because it's sort of draining your body's metabolic demand. We've talked about malabsorption, and we mentioned hypothyroidism as well. So good ones. On the other hand, you can look at weight gain. So I think the most common one is exogenous obesity, so just from sedentary lifestyles and poor diet choices and things like that. Something else which is really interesting is fluid. When people think about weight gain, they don't often think about fluid. They think about, weight from food, right? But food is actually fluid overload is a very, very common cause of weight gain. So whenever someone asks you about weight gain, don't forget to think about fluid. That could be in cardiac failure. It could be in nephrotic syndrome, in chronic kidney disease. It could be as simple as getting ankle swelling from a calcium channel blocker, okay? So whenever someone puts weight gain to you and asks you for differentials, always consider fluid overload as well. There's a few obvious ones like pregnancy, but I guess it's a pitfall. Lots of drugs, a few diabetes drugs in particular can do it, and on the other spectrum of the thyroid, so hypothyroidism, when you have a slower metabolic rate. So a few good ones there. Taking a weight-related history. So rather than just asking someone, tell me about your diet and exercise, if you've got a bit more time, these are some good questions to ask. The big one is probably the second one. So how much weight did you lose or gain? And was it expected or unexpected? Okay, so obviously unexpected weight loss, you're worrying about malignancy. You can ask them about previous weight loss or weight gain attempts. And then going through asking about takeaway and home cooked meals and do you get vegetables? They're 3 quick, easy questions to ask as well. Okay, so now we're going to move on to the liver. So, who wants to label all those structures for me? No, I was kidding. So, with anatomy, just briefly, if you can, so it's good to remember a little bit. I think the portal venous system is the most clinically relevant part here, but just very quickly, anatomically, you have your 2 lobes, the right and the left one, anteriorly divided by the falciform ligament. If you flip it over to the back, you can see the physiological or functional divisions. So there's that H there, if I can get the mouse to work. This H is quite important. So that's what lobe? It's either left or right. Left, yep, right. Caudate and quadrate. So I've got the IVC and the gallbladder there, and then the porta hepatis, okay? So just remember you've got anatomical divisions and also physiological divisions. Moving on to the more clinically relevant parts, the portal venous system is really important, especially when you're talking about chronic liver disease and portal hypertension and sequelae or complications of cirrhosis as well. So this is quite a nice diagram taken off Galaxy slides from way back, but that's liver, that's the splenic vein, superior mesenteric vein as well, and it forms that nice little shape. So the clinical significance, I guess, this is the final pathway for venous blood to return to from the spleen, the pancreas, the gallbladder, and most of the abdominal part of the GIT, except when you get down to the inferior rectum and the anal canal. But it all goes through the portal vein. So it's the joining of the superior mesenteric vein and the splenic vein, goes to the portal vein, and then it goes to the liver. So it passes through the hepatic sinusoids, it goes through the hepatic veins, and then it goes back to the IVC. So just think of this as like a bypass system. So instead of going from, heart to muscle, muscle to heart, it goes heart, gut, liver, and then heart, okay? In terms of acute liver disease, so a nice definition is it's severe acute liver injury, and it's characterized by a decline in hepatic function, and by definition, that's two things. So it's hepatic encephalopathy and a coagulopathy, so an INR of 1.5 or more. What's the normal range for an INR? More specifically? Anyone? Okay, 0.8 to 1.2. It's a good bracket to remember. And also, it's in a patient without pre-existing chronic liver disease, okay? Sometimes you can get acute on chronic, but that's a bit different. So hepatic encephalopathy, coagulopathy are an INR of more than 1.5, and they shouldn't have any chronic liver disease. The most common cause is paracetamol toxicity or paracetamol overdose, okay? There's many other causes as well. So there's idiosyncratic drug reactions. Lots of drugs can do it. Some antibiotics, some NSAIDs, some anticonvulsants. There's viral hepatitis and autoimmune hepatitis, which we'll talk about in their own categories. A few of the other smaller ones, ischemic hepatitis. So it's an organ. So if you have poor perfusion to an organ, it's not going to work as well, particularly in hypovolemic shock. You can get ischemic hepatitis. Alcoholic hepatitis we'll talk about a bit later. Wilson's disease, excessive copper deposition. What sign would you see in the eyes with Wilson's disease? Everyone? Good. Kaiser flash rings, yes. And Budd-Chiari syndrome is another one as well. Does anyone know what Budd-Chiari syndrome is? It's hepatic vein. It's hepatic vein thrombosis, okay? It's different to portal vein thrombosis. Yeah, so there's a few other causes as well, but the main cause of acute liver disease is paracetamol overdose. In terms of presentations, so you can get very non-specific ones, fatigue, lethargy, malaise, a few very general abdominal ones as well. Hepatic dysfunction, so that's kind of moving on a bit further. So that right upper quadrant, it's often more discomfort, or it's a nagging sort of discomfort rather than pain specifically, but it can be painful. Jaundice due to the raised bilirubin, pruritus and hepatomegaly as well. And then by definition. So I want to explore that definition a little bit further. So what is hepatic encephalopathy? Or what is encephalopathy?
Derangement of essentially the brain's function.
Yeah, good. So yeah, derangement or I guess progressive deterioration in cognitive function. And as you can see with the West Haven criteria, that can range from just being a little bit confused to having an altered conscious state to being in a coma due to cerebral edema, okay? So yeah, it's a deterioration in cognitive function, hepatic encephalopathy caused by the liver. So why would you see it in acute liver disease? Does anyone know? Yeah. So there's, I guess, two major theories, but one of them has to do with ammonia, essentially. So there's the accumulation of toxic substances. So if we go back to the function of the liver, one of the functions of the liver is that it sort of clears toxins. So in acute liver disease, you probably won't lose that completely, but that function will be altered. So you can get an accumulation of toxic substances, specifically ammonia, that can cross the blood-brain barrier, and it can affect astrocytes in the brain. So that's why it causes hepatic encephalopathy. So that's the first one. Just quickly with hepatic encephalopathy, that's the West Haven criteria. So it ties in consciousness, intellect and behavior, and also neurological findings. So if you suspect someone's in acute liver disease, it's important to do a neurological exam. They might have a mild hepatic flap at first, and then in later stages, they can get hyperreflexia as well. So the next part of the definition, so hepatic encephalopathy and the coagulopathy. So prothrombin time, or international normalized ratio, is a measure of the extrinsic coagulation pathway. Again, why is that significant? If you go back to the function of the liver produces clotting factors, okay? So again, in acute impairment, the liver isn't going to be able to produce those clotting factors as well. And that's why it's going to take longer for blood to clot, which is why you have a raised PT or INR. Does that make sense? So whenever you look at pathology, always take it back to the function. So what does a liver do? It clears toxins, and it's involved in the production of clotting factors, okay? So that's why you get an increased INR and you might get hepatic encephalopathy, acute liver disease. In terms of investigations, so whenever you're ordering investigations, it's always good to justify them. So a urine toxicology screen is important, especially for paracetamol toxicity. Pregnancy, there's something called HELP. You can look it up later if you want, but it's generally seen in preeclampsia. There's lots of blood tests you can do. Obviously, the specific ones, or the important ones here, are LFTs. So you might see a high bilirubin, and what else might you see on LFTs? Intrahepatic disease, raised. Yep, ALT and AST, good. And obviously, if you do a coagulation studies, you'll see an elevated INR. Imaging, you can consider a abdominal ultrasound with Doppler, and consider a CT as well. And then depending on if you've ruled out, I guess, paracetamol toxicity, which is probably the most important one to rule out early, then you can start looking towards what are the other specific causes of this person's acute liver disease. In terms of causes of significantly elevated transaminases, so I'm talking well over the 1,000 mark, these are the big ones, okay? So paracetamol overdose, ischemic and autoimmune hepatitis. Viral hepatitis can be significantly, or it can be moderate. Alcoholic hepatitis is generally a moderate elevation of transaminases. And then when someone has chronic, maybe like hepatitis for a long time and it's not really doing anything, that's when they can have slightly elevated transaminases. But significantly elevated transaminases, well over 1,000, paracetamol overdose, ischemia and autoimmune causes. In terms of, oh, this is great. Anyway, management, it's pretty much all there. The important ones are in blue. So with any sort of crisis situation in your OSCE, start with, I would follow doctors ABCD, EFG, which stands for don't ever forget glucose, and look for hemodynamic instability as well. Obvious things, so avoiding hepatotoxic medications, because people with acute liver disease are at increased risk of bleeding. Maybe looking at some prophylaxis there as well, and a few other things as well. So treatment of the underlying cause, and if you're interested, you can look up the King's College criteria, which is a good set of criteria for liver transplant as well. So that's just a nice picture which kind of ties in all the aspects of managing a patient with acute liver disease. In terms of acute viral hepatitis, so now we're going to talk about viral hepatitis. So the acute ones are generally hepatitis A. Hepatitis E is very rare in Australia, but I thought it might be good to mention. So we'll stick to hepatitis A for now. The important thing to remember is it's fecal-oral transmission. So things like hand hygiene, ensuring good food preparation, all that sort of stuff is important. It's mostly self-limiting though. So it rarely kind of progresses to fulminant hepatitis, which is, I guess, severe, very sudden and very bad hepatitis. And it's a common culprit in sick people returning from overseas holidays. So when you have your history station in your OSCE, which asks about, I don't know, maybe fever, or in a return traveller from overseas, always think about hepatitis A. Hepatitis E is more or less the same. It's very common in India and Southeast Asia. And if a pregnant woman is infected with hepatitis E, you need to consider for hospitalisation straight away. For some reason, they have an elevated mortality. In terms of presentation, it's similar to what we talked about before, and always remember prevention is very important. So with hepatitis A and hepatitis B, there is a vaccination. not yet with hepatitis C, and also looking at improved sanitation. Still important in Australia, but more important in the developing world as well. So moving on to the chronic liver disease spectrum now. Okay, so we're done with the acute liver disease. Now we're moving more to the chronic side of things. So chronic viral hepatitis, it's a double-stranded DNA virus. According to the WHO website, about a third of the population actually have had hepatitis B at some point in their lifetime. Obviously, not all of them have active hepatitis B. And it's highly common in sub-Saharan Africa and East Asia. Again, prevention is key. Methods of transmission. I have a very good way of remembering methods of transmission for hepatitis A, B, and C, but I'm being recorded, so I probably shouldn't say it, but I'll say it at the end for you guys at the lecture when this has been turned off. But blood is blood products, so horizontal transmission. So that's generally in the early stages of life by transmission through, touching other people, kids touching other kids' hands in their households and things like that. So generally between family members within households in early life, and that can be through sort of non-intact skin or mucous membranes with active virus in the bodily fluids, and then all the other things to do with blood. So blood transfusions in hospital, if they've got tattoos, there's always a risk of hepatitis B. Sexual intercourse as well, and in brackets are risk factors for sexual intercourse being a transmission risk for chronic viral hepatitis, and vertical transmission, so when a mother's giving birth essentially. This next picture is important. So pretty much hepatitis B, if you had to pick a hepatitis to get, or you'd probably say A or B, and the reason being is during adulthood, because most people in adulthood clear the hepatitis B virus. This picture says 95. I've heard about 90 or 85, around that mark. So most people that get hepatitis B in adults actually clear the virus. So it's pretty good in that aspect. However, there is 5 to 10% that develop chronic infection. And of those people that develop chronic infection, about 15 to 20% will get cirrhosis. It's very different. It's a very different story in childhood, which is why I was emphasizing horizontal transmission in early life as well. When you get it as a kid, you can see 90% of children develop chronic infection, okay? Which is probably why it's so high in terms of prevalence in the wide world. But yeah, so generally as an adult though, you're more, most people clear the virus. Okay, in terms of phases of chronic HBV infection, I think that this picture is a very good way of summarizing it. But briefly, there are 4 steps. So I guess the progression of hepatitis B is determined by the interplay between the virus and how it's replicating and the host immune response as well. So phases 1 and 2, that's sort of the early, in like the brighter yellow, that's the early replicative phase with active liver disease. And the second part is when there's sort of going into remission, I guess. So the 4 stages, first one's immune tolerance. So that's when you have a higher level of HBV replication. And it's often asymptomatic. There's sort of no evidence of active liver disease by the patient's presentation or on biopsy either. The second stage is immune clearance. So that's when the immune system starts to fight back, attempting to clear the virus. So you get those kind of reducing levels of HBV DNA, and you start to get those abnormal levels of ALT. Then the body looks to immune control, which is, I guess, inactive carrier state is pretty much knocks it on the head. So it's where you get remission of liver disease and you get undetectable HBV DNA in your serum, and then immune escape. So that's essentially reactivation of the viral process. Yeah, so according to guidelines with immune tolerance and immune control, so if someone's in those 2 stages, you can just monitor them, every about 6 months to a year. However, if they're in the immune clearance stage or the immune escape stage with abnormal liver function test, that's when you need to get specialist referral. Okay, so this is not so much examinable, but it's more for interest and understanding of the progress of the disease. This, on the other hand, is extremely examinable and very important. So now we're going to go through symptoms and signs of chronic liver disease. So, by the way, viral hepatitis isn't the only cause of chronic liver disease, but it's the main one I want to focus on for now. So, leukonychia. Firstly, what is leukonychia?
White spots on the nails.
Yep, white discoloration in the nails. Good. What is it indicative of? hypoalbuminemia. Again, okay, so let's bring that back together. Sorry, I haven't filled out this table, but I'll do it when I upload the slides later. Yeah, so why is that significant? Because remember, the liver produces albumin, okay? So in liver disease, liver's not working as well, you don't produce as much albumin, you get leukonychia. I've grouped spider nevi, palmar erythema, and gynecomastia, or breast formation, together because they are all signs of, good, hyperestrogenism. The liver, one of the roles it has is it can metabolize estrogen. So obviously if it's not working, it's going to fail to do that, and estrogen can accumulate. Scleral icterus, or jaundice. Why do you get jaundice? What causes jaundice in one word? Yeah, hyperbilirubinemia, so high levels of bilirubin. Purpura or other aspects of coagulopathy, again, going back to the function of the liver, because the liver produces clotting factors. Hepatosplenomegaly, ascites, and peripheral edema, all to do with fluid and portal hypertension, which you could say is a sign or I guess a complication of chronic liver disease, but it's to do with portal hypertension, which we'll talk about a bit later. Hematemesis and melena, why might you get that in the context of chronic liver disease? Okay. Yep, portal hypertension, more specifically. Varices, yeah, so the rupture of generally esophageal varices. A few others, so hepatic encephalopathy we've talked about, and you can also get something called hepatorenal syndrome. If you don't really need to know much about it, but I guess, yeah, there are two types. Type 1 is more acute, type 2 is more chronic. If you're interested in doing some reading, you can, but it's essentially just changes in the vasculature or the perfusion of the kidneys due to changes in the liver. That's, I guess, a very brief summary of it. You can also get extra hepatic manifestations. You can see like a serum sickness-like syndrome very earlier on. There are some extra hepatic complications. In terms of investigations, so deranged LFTs, hyperbilirubemia, hypoalbuminemia, and a raised PT and INR. Does anyone know why you might see a thrombocytopenia?
Splenomegaly.
Okay, yep, so it has to do with splenomegaly. So pretty much with the enlargement of the spleen, you see something called sequestering of the majority of the total platelet mass. Okay, so that means the spleen hangs on to the platelets for some reason. And that just means you have less platelets floating around in the blood. So when they measure your blood, it doesn't look like there's many platelets. Okay, so thrombocytopenia. Okay, so make sure you've got a really good handle of that. Okay, with your Ruskies, this would be quite mean to do, but they could certainly do it. And they have done it in the faculty released exam questions, which I have on my PowerPoint. Again, this is taken from the RACP guidelines, which is one of my favorite resources if you haven't noticed already. But down the bottom is essentially their guide to analysing it. And I've added the words in orange. So yeah, obviously that's not on the RACP guidelines. So there's three aspects to it. There's three antigens with the hepatitis B virus: the surface antigen, the surface antibody, and the core antibody. So this is how I kind of think about it. So HBsAg, so G, that starts with GOT, so GOT starts with G. So if that's present, they've got it now. Okay, that's the way I remember it. If they've got the anti-HBs, ends in S, SLADE, starts with S, they've slayed the virus, or they've, defeated the virus, whether that's by vaccination or infection. And then anti-HBC is they've caught it, so C for caught. They've caught it at some stage in their life, whether it's now or in the past, okay? So that's how I remember it. These are a few questions. They are pretty tricky, but I'll give you a couple minutes to have a look at it. So have a go with the people around you, and see how you go. All right, so again, this is quite difficult, but did anyone manage to come up with an answer for any of them? First one's J. No, the first one's F. Okay, so some people actually did do it. Okay, good. Okay, I'll try to go through it best I can. So I'll just get to the crux of it. So previous hepatitis A, the reason it's previous hepatitis A is because the anti-HAV IgM is negative. So remember, IgM spikes first, and then you get the IgG. So if the IgM is negative and the IgG is positive, it's, they've had hepatitis A in the past. So that's why it's previous hepatitis A. In terms of the hepatitis B serology results, so HBsAg is negative. So remember, G, got it now. So they obviously don't have it now. Anti-HBs is positive. So they've slayed or defeated the virus at some point in their life, whether that's an immunization or infection. And they've caught it. So again, IgM is negative. Now, we don't know if that means, so that rules out an acute infection, but they don't tell us about IgG. So it could be chronic infection or immunization. So that's why the answer is F. Does that make sense? Okay. Moving on to the second question, question 11. Anyone have an answer for question 11? Not A. Okay, it's D. So for well, these are my opinions, but I'm pretty sure they're right. Hepatitis B carrier state. So it's not HAV or hepatitis A because the IgM and IgG is negative. So G, remember, HBsAg positive. Got it now. Have they slayed the virus at some point? No. But again, their IgM is negative. Okay, so it's a hepatitis B carrier state. And then the last one.
So why isn't it acute as opposed to carrier? How do you differentiate?
Because they don't have it now. Yeah, and there's no IgM. And question 12. Yes, good. Question 12 is J. So recent hepatitis A infection because the IgM is positive, and then hepatitis B immunization. So do they have they got it now? No. Have they slayed the virus? Yes. Have they caught it? No, because the anti-HBc IgM is negative. So they've never actually caught it, but they've beaten it, right? So that implies immunization. Okay. So what I might do is I might write some explanations and post them up to help, because that might be a lot to take in at the moment. All right, getting back to the lecture. Okay, so chronic hepatitis C. Type of virus is there, incubation period. Yeah, the main thing to remember here is transmission is mainly by IV drug use, okay? So if you get this in a STEM and it says IV drug use, highly likely to be hepatitis C. Hepatitis C can be caused by other things as well, so blood contamination and sexual intercourse, but it's very commonly seen in IV drug users. Can be exacerbated by alcohol use, and also it's not uncommon to see HBV and HCV co-infection. Okay, so different to adulthood hepatitis B, 80 to 85% of people develop chronic hepatitis. Okay, so this is why I said it's probably the one you don't want to get. In terms of treatment, they've used combination therapy in the past and somewhat currently as well. It's interferon alpha and ribavirin. I've heard there's lots of studies and research trials looking at newer treatments for hepatitis C, which are very good but very expensive. And hepatitis D, very briefly, it's not very common, but the only important thing to know is that you need hepatitis B co-infection in order to get hepatitis D, because otherwise the virus won't thrive. Okay, yeah. That's a nice summary of the A, B, and C's of viral hepatitis. Okay, so I mentioned there are other causes of chronic liver disease apart from viral hepatitis. So there's alcoholic liver disease, which is the one everyone thinks of when they think of cirrhosis. But just remember, chronic liver disease and cirrhosis, not just hepatitis and alcohol, but alcohol is one of them. So on history, make sure you assess how severe their drinking is. Might even be appropriate to ask them about CAGE, if anyone still remembers that. There's 3 different stages, which you can read of later. On examination, you might get some chronic liver disease signs, but also think about signs which are specific to alcoholism. Not necessarily chronic liver disease, but specific to alcoholism. Does anyone know what I'm talking about or referring to? Dupuytren's contracture, and also parotid gland enlargement as well. Okay, so there are some signs which are sort of tied to alcoholism. In terms of supplementation, it's important to think about giving, replenishing their vitamins as well, and that's what you can see on histology. Another cause of chronic liver disease is NASH. So NASH falls under it's the umbrella term is non-alcoholic fatty liver disease, and that encompasses both simple steatosis or simple fatty liver and NASH, which is a more severe form of steatohepatitis. And the important thing here is, so this is just pretty much eating lots of fatty food, and that can affect your liver. And yeah, it needs to be considered in the context of metabolic syndrome, because that's probably more likely to kill you than your chronic liver disease and cirrhosis. Okay, so the last little bit with chronic liver disease is sort of triggers and management. So again, it's kind of like, you'll often see this pattern in hospitals where, say for COPD, someone, apart from their fresh diagnosis, they might not present to hospital with COPD, but it'll be an acute infective exacerbation of COPD. Similar sort of concept with chronic liver disease. There's something that's happened that's triggered sort of the acute on chronic, or the worsening of their condition. So my question is, what causes patients with chronic liver disease to progress to a decompensated state? And these are some of the things which can cause that. So severe infections can make them from just going okay with chronic liver disease to suddenly very bad. Drugs can do it, failings in other parts of the body, and bleeding. So in terms of management, the basics, so always start with trying to identify what the cause is and then treating that. In terms of your encephalopathy, does anyone know how you might treat someone with encephalopathy? Okay, so you can give lactulose, or an osmotic laxative, and it's just pretty much trying to get rid of some of that fluid. It can also lower the pH, which is harmful for gut bacteria. So that's pretty much it for encephalopathy. You can get something called, does anyone know what SBP stands for? Oh, it's on. Yeah, good. Spontaneous bacterial peritonitis. So that's just sort of when you get infection on top of your ascites. So that's important. So if that happens, you need to do a acidic tap to try and analyze that fluid. So to check for, glucose cytology, if there's hepatocellular carcinoma, and a few other things there as well. And then you might consider giving them an albumin IV infusion. The fourth one, coagulopathy. So again, when we sort of talked about acute liver disease, we cover this, but you can give them vitamin K, and depending on how bad their coagulopathy is, you might look at fresh frozen plasma, and a few other different things, and then hepatorenal syndrome. So again, the treatment is albumin infusion, but yeah, you don't really need to know too much about that. Okay, so liver cirrhosis. So that's a definition of cirrhosis. So it's a diffuse, irreversible pathological process. I kind of think of 3 things: loss of normal liver architecture, and then loss of function. You get fibrosis due to all the inflammation, and you get regenerative hepatic nodules as well. You can classify cirrhosis by etiology. So it might be caused by hepatitis, viral hepatitis. It might be caused by NASH. It might be caused by alcoholic liver disease. You can classify it in morphology and morphologically. So you might see nodules which are greater than 3 millimeters, which is generally to do with alcohol, or you might see a micronodular picture, which is generally to do with viral hepatitis. In terms of classification, it's very important to know this classification. So you can have compensated liver cirrhosis and decompensated liver cirrhosis, which is a really bad one. So it's pretty much based on whether you have ascites or varices. Okay, so compensated stage 1 is no ascites and no varices. Stage 2 is varices but no ascites. Stage 3 is varices and ascites. And then stage 4 is when you get variceal rupture and variceal bleeding and ascites. Okay, so just remember, if you can't remember all of that, just remember varices and ascites are the key sort of indicators in whether someone has compensated or decompensated liver cirrhosis. Okay, so in terms of pathophysiology, I'll try to keep this as simple as I can. I do want to go over it because it's important for portal hypertension. So you get hepatocyte death, and that's just due to prolonged insults. Okay, so if you've got, from the virus, from alcohol or whatever. So you get death of the cells in the liver. With any sort of necrosis, you're going to get inflammation. Okay, so, and that's caused by the Kupffer cells, which are specialized macrophages. That activates the stellate cells to deposit extracellular matrix, and that's what's causing the phenomenon of fibrosis. Okay, so how does fibrosis lead to portal hypertension? It all comes back to vascular reorganization. So what happens with fibrosis is these fibrous bands form throughout the liver, and when you get fibrosis in the liver, they can obstruct parts of the venous system. Okay, so it's actually like resistance to parts of the venous system. So when you have increased resistance, you get increased pressure, and that leads to portal hypertension. Okay, so what happens next? So portal hypertension is increased in blood pressure in the portal venous system. It can have multiple causes, but let's just focus on cirrhosis for now. So these are the common sequelae of liver cirrhosis. So you can get an ascites. So the reason you get an ascites is you get increased resistance to blood flow in the portal vein, and you get increased pressure. And with increased pressure, you can get net movement of fluid out of the veins, and it can land in the cavity. Okay, so you get ascites. That's the first one. With portosystemic shunts or varices, you can get an increased pressure in the veins, especially where the collateral circulation joins the portal circulation. And then the veins sort of become dilated and tortuous, and over time, when they get really big, they can rupture, and that's when you get upper GI bleeding. And then the last one is splenomegaly. So pretty much, instead of blood going from the lower abdomen to the liver, because of that, because of the resistance, you just get backflow and congestion. So that's why the spleen gets big. Okay, so all this comes back to portal hypertension, which comes back to the fibrosis causing increased resistance. Later on, you can get liver failure and hepatocellular carcinoma. The Child-Pugh score is a good way of sort of measuring the prognosis of liver cirrhosis. So it's good to know. And there's a nice picture of all the little things we've talked about. All right. So by the way, I'm aiming to try and be done by 7:45, 7:50, and I think we're on track for that. So let's go over some questions. Does someone want to yell out when they think they have an answer? Anyone? Please. Pancreatitis, okay. Good suggestion. There's actually a few this could be, but there's a reason I think it's one of them, and I'll explain that in a minute. Peptic ulcer? Anything else? Okay, so this could be a few things, but I actually think this is an aortic aneurysm, and I'll explain why. So the epigastric pain radiating through the back could be pancreas because it's a retroperitoneal organ. Could also be a peptic ulcer that's burst. The reason I think this is an aortic aneurysm is they're specifically mentioned sort of vascular risk factors in the question. Okay, this is my personal opinion. This one's been a little bit controversial, but this is why I think this is aortic aneurysm. They've mentioned specifically the cabbage. Obesity and smoking can be lots of things, but I think the past history of cabbage, they didn't have to put that in, but it seems to me that this makes me lean towards an aortic aneurysm more, because obviously smoking and obesity can also contribute to atherosclerosis, causing an aortic aneurysm. The aorta is also a retroperitoneal organ. Okay, so can you see where I'm coming from there? It could be the other two, but I would lean towards aortic aneurysm. Here's the next question. So thank you for those people who gave me their answers. Does anyone know what the X-ray shows? Pardon? What's that? What do you mean? Oh, yeah. Oh, not bowel perforation. Oh, but perforation, yeah. Pardon? Someone said it behind you? Yeah, gastric ulcer perforation. Okay, so he's taking diclofenac. What's diclofenac? NSAID, okay? So straight away within the first sentence of the question, you're already starting to suspect gastric ulcer. Severe epigastric pain also suggests gastric ulcer. The blood pressure of 90/40 suggests he's already lost a lot of blood. So again, gastric ulcer, common complication is perforation, hemorrhage. And in this case, it's probably already perforated viscous. So generally with perforated viscous, which could also happen with bowel and a few other things, you see pneumoperitoneum, or this little line here. Okay, that shouldn't be there. And that's why, because it's, perforation of a viscous, hemodynamic instability, you need to rehydrate them straight away and send them off for laparotomy. Make sense? Just nod or shake, don't have to talk. Pardon? So because it's, okay, so this looks like a gastric ulcer perforation, caused probably by his NSAIDs, given the question. So antibiotics probably isn't warranted. And also, you've got to pick the best answer. This guy needs to be rehydrated straight away because of that poor blood pressure, and because there's a perforated viscous, he needs to be in surgery now. Does that make sense? So it's about choosing the best answer. All right, next question. So yeah, this one's, you kind of need to know the antibiotic and the adverse effects of it or not. Anyone hazard a guess? Yep, esophagitis, that's the answer. You could sort of have an educated guess, severe retrosternal chest pain. Yeah, I guess one of the common side effects of tetracycline is esophagitis. Okay. Question, the first one, or question 34. C? Yep, I'd agree. The next one, are we still going? Okay, I'll help you out. Oh, I don't think I put the answers. I'm going to highlight the keywords. What Wouldn't that be great if you had that in the exam? Okay, second one. I'm just wary of time. I want to keep moving. I, yep. And the last one. Pretty much highlighted the whole paragraph, but. A, yep, A. Okay, so let's just quickly go through them. So I think the first one is C, because so acute pancreatitis, so severe constant epigastric pain radiating to his back. The pancreas is a retroperitoneal organ. We'll talk about pancreatitis next week, but the most common cause is ethanol or alcohol. The second most common cause is gallstones. Okay, so this is getting you to think that about gallstones causing pancreatitis as well. The second question is large bowel obstruction. Again, we'll talk about lower GI next week, but pretty much abdominal distension and bowels not open for not even 5 days, but if bowel's not open for 5 days, it's definitely bowel obstruction. When you see someone with bowel obstruction, they generally have quite a distended abdomen due to all the gas that's kind of built up. And question 36, we said was A. We'll talk about cholecystitis later, but female, not necessarily in her 40s, but in this case she's been in her 30s, right upper quadrant pain, worse with eating food, and right upper quadrant mass as well. Sorry, it's the exact same question. These questions were taken from the faculty-released Monash Year 3 exams, by the way, so this is quite similar to what you'll get on your actual exam. Okay, everyone should have the first one by now. What is it? Read the third line. Yep. So high doses of ibuprofen also being an NSAID. Yep, G. I'll explain that in the last one. C, good. So yeah, high doses of ibuprofen and vomiting blood, peptic ulcer, varices. So he does not take alcohol, kind of rules out a Mallory-Weiss tear generally. But yeah, so it's kind of long-standing hepatitis. So hepatitis is probably the cause of his chronic liver disease, portal hypertension, that sort of thing. And the gastric cancer, lymph node involvement, and yeah, poorly defined mass. Anytime you see that in the question, you've got to start worrying. Okay, so in the last 10, 15 minutes, we'll go through the rest, which isn't much. So hematemesis and melena. So hematemesis is the vomiting of blood. Melena is that sort of black tar-like feces. It's caused by, I guess, hemoglobin being altered by chemicals in the gut, and it's been in the GIT for a while. And then hematochezia, which we'll talk about next week, is a passage of bloody red stools. Location's important, so the ligament of Treats, has anyone heard of that? Does anyone know where it is? Yep, suspensory muscle of the duodenum. And it actually demarcates the formal division between the foregut and the midgut. So just a good fact to know. With vomiting up blood, so you can get melena, but you can also get bright red vomiting or coffee ground vomitus, okay? So bright red vomiting, usually, you know, when you see bright red vomiting, it's like frank blood. So it might be due to a Mallory-Weiss tear, which by definition is, you know, prolonged vomiting causing trauma or a tear. Whereas coffee ground vomitus is more, you know, the blood's been in, you know, the system for a while and then it comes back up. So that's generally more duodenal gastric causes. something to think about, a brisk upper GI bleed or a big GI bleed can also present as hematochezia. So hematochezia might be bright red blood on stools, which might be hemorrhoids or something, but it's also something to think about that it could be a very quick bleed or a very big bleed from higher up. Questions commonly missed when taking a history. So in your OSCE, you're highly likely to get a vomiting blood or blood in my stools station, and you must ask these questions, okay? So you need to check how much blood they've lost, which you can still get a rough guide on history. So ask, have you fainted, are you dizzy, etc. Anticoagulant medications and bleeding disorders, these won't cause vomiting blood on its own, but they can exacerbate cases of vomiting blood, and also ask if they've had recent abdominal surgery or endoscopy. Investigations are as below. It's important to try and identify the source of bleeding. And a red cell scan is when you you take a bit of blood from a patient, you label it with a radioactive isotope, and then you put it back in, and then you sort of perform a nuclear scan to try and find the source of the bleeding. But gastroscopy is also pretty good at doing that. Okay, in terms of etiology, so peptic ulcer disease, number 1. Esophagitis is another one. Esophageal varices. Esophagitis you can often see alongside GORD. Esophageal varices, we talked about in hypertension. Portal hypertension. A Mallory Weiss tear. So it's tear in the mucosa, often caused by alcoholism. Can also be caused by eating disorders. Gastroduodenal cancer, so you'll see more systemic things like weight loss, and vascular malformations, which you can read about a bit later. I won't talk about management because I want to move on. All right, so common presenting complaint of jaundice. Hopefully this works for me. Yes. Okay, so what is the definition of jaundice? Yeah, so it's a sign. Yeah, that's good. So it's a clinical sign, and it reflects the accumulation of bilirubin in the blood. And then that bilirubin goes to different places. So you can get it in the sclera, which is often where you see it first, the mucous membranes and the skin. Does anyone know the number or the level at which jaundice becomes clinically evident? Close, 34. Okay, so when it's twice the upper limit of normal. Where does bilirubin come from? Yep, good Mac. Hemolysis of red blood cells. So yeah, remember there's 2 components to hemoglobin, heme and the globin. The heme is the one that gets converted to bilirubin in its lipid-soluble unconjugated state. And how can we classify jaundice? Yep, prehepatic, intrahepatic, extrahepatic. Okay, that's jaundice. And there are 2 lovely pictures there as well. This is a table taken from my notes. And it just kind of shows you how you can split it up into pre-hepatic, so pathology occurring prior to the liver. So generally when you see increased production of bilirubin, generally due to hemolysis. Intrahepatic, so this can be due to a few different things. So it can be the liver's unable to uptake bilirubin, it's unable to conjugate it, or it can be due to damage. And then post-hepatic jaundice, which is pathology occurring after the liver, and it often involves a biliary tree, and it's often also called obstructive jaundice, okay? So it's often due to an obstruction. That can be an extramural obstruction, an intramural obstruction, and an intraluminal obstruction. So extramural might be something like cancer of the head of the pancreas, compressing the biliary tree from outside. Intramural, primary sclerosing cholangitis, autoimmune condition commonly seen in females. And then from the inside, so a gallstone or a cancer itself. Just quickly with liver function tests. So I put function in inverted commas because they're not actually really measures of liver function. They're more measures of liver damage, okay? So true liver function markers are albumin, coagulation, and all those other things. AST and ALT, often to do with intrahepatic jaundice, and ALP and GGT obstructive or post-hepatic jaundice. It is a little bit more complicated than that, but we'll talk about that a little bit later. Okay, so I'll try and dumb this down as much as I can. So you have unconjugated or lipid-soluble bilirubin in the blood, and that's why it's bound to albumin, and then it goes into the liver. So in the liver, it gets conjugated. So It's a very complicated process, but it gets conjugated with glucuronic acid via this enzyme, and that makes it water soluble. And that's important because now it can be excreted into the bile. So then you've got water soluble bilirubin, all conjugated bilirubin ready to go. Most of it is actually reabsorbed into the hepatic circulation, but then bacterial enzymes in the bowel break that down to urobilinogen, which mostly goes into the feces. Why have I told you all of this? I'm not sure, but it kind of relates to this question. So does anyone know what urine or stool changes you would see in a patient with obstructive jaundice or post-hepatic jaundice? This is important. Good. Pale stools, dark urine. And I'll try and explain why that occurs. So I'll just flick back to this picture. So you see, okay, so the reason you get, so this, we're talking about obstructive jaundice. So you have an inability of, so imagine just put a big cross here. You have an inability of conjugated bilirubin to reach the bowel for conversion to urobilinogen, okay? So the conjugated bilirubin, it can't go down because there's an obstruction. So conjugated bilirubin has got to be excreted somehow. Usually it goes onto urobilinogen and most of that goes into the feces. Because there's an obstruction, conjugated bilirubin enters part of it, the water-soluble bit, enters the bloodstream, and it's later excreted by the kidneys. So you've got more conjugated bilirubin excreted by the kidneys, so that's why you get darker urine than expected, and you've got less conjugated bilirubin being excreted in stools, which is why you have pale stools. All right? So that's a bit of an explanation. It might make more sense when you read it at home. That's a nice table from Wikipedia. History taking in the OSCEs, that's from my notes. So if someone comes in with jaundice, just do that and you'll do pretty well. A few other things. Can you identify the differential diagnosis for jaundice based on these investigations? So if someone comes in with jaundice, you wouldn't do all these investigations, but if you think it might be something in particular, you might order one of these. So viral serology is for viral hepatitis. This is good for buzzwords as well. Antimitochondrial antibodies. Anyone know which condition you might see that? Yes, so primary biliary cirrhosis. P-ANCA, which stands for perinuclear anti-neutrophilic cytoplasmic antibodies. PSC, so primary sclerosing cholangitis, which you might see as an extra-intestinal manifestation of inflammatory bowel disease. Anti-nuclear and anti-smooth muscle antibodies. Autoimmune, good. Ferritin and transferrin. Iron studies, why are you ordering iron studies? Hemochromatosis, yep. Ceruloplasmin, this might be a hard one. Wilson's disease. Alpha-1 antitrypsin is for alpha-1 antitrypsin deficiency, believe it or not. And a hemolysis screen. Yeah, so looking at causes of pre-hepatic anemia, so pre-hepatic jaundice, such as hemolytic anemia. So they're the components of a hemolysis screen. You don't need to know much about these antibodies, but just if you can, try and remember which antibody goes to which condition. That's quite important for your EMQs. All right. So essentially, it's important to know this anatomy. It's also important to know how to draw this anatomy because it's a very common presentation and people will ask you, if you need to explain it, often drawing this diagram is very helpful. So you get the bile ducts converging, form the right and the left hepatic duct. The right and the left hepatic duct go to the common hepatic duct. The cystic duct from the gallbladder joins the common hepatic duct to form the common bile duct. The pancreatic duct joins the common bile duct, and then you go to the duodenum. The borders of Callow's triangle are also very important. So it's a cystic duct, the common hepatic duct, and the inferior edge of the liver. Okay. So we're almost finished, I promise. It's important to know these definitions. So, and this kind of helps in your understanding. So cholestasis, it's when you get stasis of bile, essentially. So bile can't flow from the liver, where it's made, to the duodenum, where it's stored, to the duodenum, to where it needs to go. Cholelithiasis, lithiasis means stones. So that just means stones in the gallbladder. Biliary colic, does anyone know why I put colic in inverted commas? It's not actually a true colic, it's a misnomer, it was poorly named. So colic generally implies intermittent pain. Biliary colic is actually a functional spasm of the cystic duct. And it's generally constant pain, but the cutoff is around 3 hours, okay? So it shouldn't last more than 3 hours. And then acute cholecystitis, itis, inflammation of the gallbladder. So still with me? Good. Choledocholithiasis, so again, lithiasis. So now we're moving further down. So that's your stones in the biliary tree. And ascending cholangitis is often due to choledocholithiasis, and it's infection and inflammation of the biliary tree. It's called ascending. Does anyone know why it's called ascending cholangitis in particular? What does the ascending refer to? I heard someone said it. Someone said bacteria. It refers to bacteria that sort of comes up from the duodenum. Okay. There's lots of complications. Most of them are self-explanatory. A few that you might not have heard of. So Moritzi syndrome. Moritzi syndrome is actually quite interesting. It's where you have an impacted gallstone in the gallbladder, and the gallbladder kind of lofts off to one side and compresses the biliary tree. So that's Moritzi syndrome. Emphysematous cholecystitis is when you see severe infection, and you might often see gangrene as well. So that's really important to, it's a surgical emergency, and there are other complications as well, which you can read. The gallstone ileus is where kind of the gallstone and the small bowel kind of fuse to form a fistula. What is a typical demographic for cholecystitis? Yep, the 5 Fs. So females, 40s, fat, fair, and fertile. Yeah, in cholecystitis, so you'll generally get that right upper quadrant pain, but where else might it be painful? Think referred pain. Good. Shoulder tip pain. Why? Because it can irritate the diaphragm, which is innervated by the phrenic nerve, which shares innervation over the right shoulder tip. What's a characteristic sign that you might expect to be positive in cholecystitis? Murphy sign, good. So it's pain on the arrest of inspiration when you put your hand in the appropriate place. What investigations would you order? Again, pretty self-explanatory. The next question is quite important. What features would be visible in an abdominal ultrasound in cholecystitis? So think about it logically. Pardon? In choledocholithiasis, yes, but with cholecystitis, any ideas? Yeah, you can get something called cholecystic fluid associated with the inflammatory process. Probe tenderness, so when you put the probe on them, they get tender or they get pain. A distended gallbladder with thickened walls, and you might see impacted stones, specifically in Hartmann's pouch, which is the junction of the neck of the gallbladder and the cystic duct. Surgical management, a lap chole. You can also do an ERCP. There's a nice picture of that there. You can look it up because we're running short of time. Charcot's triad. Anyone know what it is? Yep, so it's associated with ascending cholangitis. What is the triad? Jaundice. Good. Right upper quadrant pain, jaundice and fever. How could you differentiate cholecystitis? So on history, so remember weight loss, examination sign. So you get that painlessly distended mass or painless mass. And on investigation is pretty obvious. Okay. In terms of one thing you might have to do in your OSCE, again, this would be pretty harsh for them to do, but I guess it's good to know in general, is how to consent for a procedure. You can read over this at home, but generally the way I present consenting for a procedure is, go through the, hi, my name's whatever. Then always assess their understanding first. Talk about why you're doing the procedure, draw a picture if you can. Talk about the procedure itself, before, during, after. Talk about risks, so general risks of any infection and then specific risks with lap chole converting to an open. And then there's a few other things there, and then give them kind of concluding advice, ask if they've got any questions, consent and document. A few questions to finish. All right, someone tell me the answer, and also someone tell me the flaw in this question for bonus marks. Right, answer? Yeah, cirrhosis with features of hemochromatosis. That's the answer, or that's what I think is the correct answer, but there is a bit of a flaw to this question. Nothing else fits, but what's weird? Exactly. Hepatomegaly is chronic liver disease. Cirrhosis, you wouldn't expect the liver to be big, right? It'd be shrunken and shriveled and fibrotic, okay? So that's a bit of an iffy one with that question, but none of the other options fit. Just because of time, just do the second one. Sorry, if you all started reading the first one. What are we thinking for 8? D? Yep. Again, I think that his ranitidine doesn't really work, is a bit of a red herring. The retrosternal chest pain, chronic smoker, regular alcohol drinker all points towards GORD. What the last sentence might be referring to is ranitidine is a histamine 2 antagonist. Proton pump inhibitors are the better drugs for GORD, so that might be why, because he's on a sort of crappy medication. This is pretty much an alcoholic, so what vitamin is he going to be deficient in? Yep, yeah, mainly thiamine. Yep, vitamin B1. So remember what I won't tell you now. So there's a lot of complex information in that question, but you really only need to look at a few words to get the answer. Sjogren's, we're talking about rheumatoid, we're talking about smooth muscle, we're talking about antibodies, autoimmune, okay? Someone yell out the answer when you've got it. Yep. Intravenous drug use, viral hepatitis. So what kind of hepatitis would this probably be? C, good. We haven't talked about this one today, but does anyone know it? So bilateral xanthelasma is very characteristic for a particular condition. She's female. Primary biliary cirrhosis. So remember that xanthelasma is commonly seen in primary biliary cirrhosis. And question 28. So all liver function tests are normal. The only odd thing is a raised bilirubin. Yeah, Gilbert syndrome. I actually had a blood test done recently, and I think my bilirubin was for some reason 1 above. And the person writing pathology said, query Gilbert syndrome. Obviously, I don't have Gilbert syndrome, but it's just kind of alluding to the fact that if all the liver function tests are normal, but the only thing that's high or abnormally high is bilirubin, then the diagnosis is Gilbert syndrome. I'll work through the last 3 or 4 just because of time. So, okay, sorry. So pretty much this guy isn't jaundiced, right? So remember, jaundice is associated with bilirubin. So if he's not jaundiced, then his bilirubin should be normal. He's not cirrhotic, but he has chronic hepatitis C. So remember when we talked about elevated transaminases, we said things like paracetamol toxicity really, really high, alcohol pretty high. Chronic processes where nothing's really happening, they'll be mildly increased. Okay, so that's why A is the answer. Does that make sense? Okay. This one's a little bit hard. Someone said it. Yep. Vascular paths with nothing wrong can generally have an acute spike of ALP, sorry, not ALP, mainly GGT. In GGT? I'm not sure why, but I know because it doesn't really fit the intrahepatic obstructive thing, but it's because it's not serious disease, it's an acute spike. Hopefully this is the last one so we can go home. Okay, it's not the last one. Oh no, we've done the other ones. Okay. So what have we got there? Fever, chills and rigor, so it's a septic picture. Right upper quadrant pain, and jaundice. Charcot's triad. Everyone? Cholangitis. I think we've already gone over these questions, but yeah, that's it. Thanks very much for coming and staying so late. If you have any feedback or anything you want me to cover for next week's presentation, let me know as well.
And thank you to the king himself, Julien, for that amazing lecture.